Good evening, everyone. I'm Dan Faulkner, Registrar and CEO at the RCDSO. Thank you for joining us tonight, and welcome to this evening's RCDSO Connect session. This session has been approved for 1 point in Category 1. As a reminder, participants are required to attend for a minimum of 40 minutes to be eligible for the CE point. RCDSO Connect is an important way the college stays connected with the profession. These sessions create space for shared learning and thoughtful reflection on how we support safe and professional dental care in a changing healthcare environment. I'd also like to take a moment to acknowledge the recent ODA annual spring meeting. It was a valuable opportunity to connect in person with many of you. Thank you to everyone who stopped by the RCDSO booth to speak with us, to ask questions, and to share your perspectives. Those conversations are an important part of how we continue to learn from the profession and strengthen our work. That ongoing dialogue is especially important as we focus on infection prevention and control, which is core to safe patient care in every dental practice. While IPAC lapses remain relatively rare, and there were 24 decisions in 2024 from our Investigations Committee, or ICRC, out of about 600 plus decisions that were issued. The college does work very closely with approximately 30 local public health units in Ontario on IPAC deficiencies that are raised to the attention of public health and don't necessarily become college investigations. Unfortunately, some of these examples suggest that there are dentists who are not keeping up with the required standards in Ontario. And some lapses can significantly impact patients, their dental teams, and public trust in the profession. This session is the first in a two-part series on IPAC, with a second session to follow on June 24th, focusing on additional strategies and ongoing practice improvement. The college is devoting 2 Connect sessions to this topic because it matters to patients and to the public. IPAC is about compliance with standards from the college and from provincial public health agencies. And it's about maintaining a consistent culture of safety, vigilance, and accountability in your daily practice. Even small gaps in processes or oversight can increase the risk of patient harm. And when these gaps continue over time and increase in number, serious consequences can result. Continuous education and reflection about your practice are essential for each and every dentist, and just as relevant and important as your clinical education. Whether you are an owner, an associate, or an employee dentist, you are professionally accountable for compliance with IPAC standards. The college continues to prioritize this work. Later this year, we will begin our review of the current IPAC standard of practice, last approved in 2018. Our goal is to revise the standard to ensure it reflects current evidence, is proportionate to the real risks, is coordinated with expectations of other oral health professions, and to the extent possible, respects the impact that our IPAC standard can have on the environment. With our inclusive and consultative standards development approach, the college will also consider the realities of practice and what patients expect from their oral health providers. I encourage you to visit the RCDSO website, where you'll find a range of IPAC resources to support your practice. These include our standard of practice, self-audit tools, and practical guidance to help you identify gaps and strengthen your processes. Taken together, these efforts reflect a broader commitment to supporting a culture of safety and continuous improvement across the profession. So that brings us to tonight's session. Over the remainder of the hour, we will hear expert insights grounded in the science of IPAC, followed by a moderated discussion focused on real-world experiences, prevention, and your professional obligations. We'll also highlight practical strategies and resources, including tools designed to help you assess your current practices and support your teams in preventing IPAC lapses. Please feel free to submit your questions throughout the session. We'll do our best to answer as many as possible through Zoom, and we'll review any questions we're unable to address today. Before I start our discussion, I'd like to recognize the privilege of gathering online this evening by sharing a land acknowledgement. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis peoples from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace our role in regulating dentists, in protecting the public interest, and strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Thank you. So, in a few moments, we'll get the session underway, but I'd like to offer a brief introduction to Dr. Sonika Singhal and Anne Augustine. We'll begin the session with opening insights from Anne Augustine. Anne is the team lead for IPAC Lapse and System Support in the Communicable Disease Control Division. She brings extensive experience in infection prevention and control across a wide range of healthcare settings, including public health, hospitals, and long-term care. Anne also serves as a subject matter expert in medical device reprocessing and has been actively involved in advancing IPAC practices across Ontario. Anne's work is grounded in both leadership and research, including her recent graduate work examining barriers and facilitators to IPAC compliance in community healthcare settings. She also contributes to provincial and national initiatives, including technical committees focused on strengthening reprocessing standards and education. And Dr. Sonika Singhal will moderate tonight's discussion. Dr. Singhal is an assistant professor and program director in dental public health at the University of Toronto's Faculty of Dentistry. And she also serves as a public health dentist with Public Health Ontario. Her work focuses on public health, policy, and programmatic research to support equitable and sustainable oral health care. Welcome, Anne, and welcome, Sonika.
Thank you. Shall I just share my slides now? Okay. Oh, I knew I was, oh, there we go. One moment while I get myself organized.
We can see them. We see the objective slide.
Okay. All right. Well, thank you so very much, Dan, for that kind introduction. And thank you to RCDSO for inviting me to come and speak this evening. I'm really excited. A little daunted by the number of people who are attending, but really excited to be presenting this evening. So my objectives for this evening are to discuss why IPAC matters and the impact of failure to follow IPAC best practices in dental care, and to discuss the Ontario context with respect to IPAC lapses in dental clinics, and to examine different facets of reprocessing, both the complex and the straightforward elements involved. So I thought I would start with this quote. To me, it level sets and really does reflect the sentiments, I think, of oral healthcare providers. So Elkland and Mariano say, "We in dentistry have the responsibility to those we serve to provide the highest level of care and to ensure the care is provided safely." So I know while this session is primarily about reprocessing, reprocessing is not the only IPAC consideration when providing dental care. So here are a few observations and thoughts that I have as a recipient of care. And when I think about oral health and why IPAC oversight is so critical. So dentistry, you guys are all about surgery all the time, right? Very surgical based. There's a lot of exposure to blood, oral secretions, and instruments need to be sterile. Many instruments are complicated and require specialized training to be able to reprocess them correctly. All the care you provide is at the patient's head. Their mouth is open, and many of the instruments being used have the potential to generate particles of oral secretions, and these particles will be of varying sizes, therefore varying ability to travel. Also, medication administration. So we think about what kind of medications are used in dentistry. Well, there's the usual local anesthetic. There's nitrous oxide. Some places use general anesthetic. So think about how are these medications managed, stored, dispensed, delivered to the patient. And then there's office design. It may be open concept, and depending on the spacing between the chairs, the ventilation, there could be a risk for cross-contamination. Or you could have operatories with closable doors. That would be ideal. But dental offices are not always purpose-built. Sometimes they're in large old houses, sometimes they're in storefronts, sometimes they're in office buildings. So design can be challenging. And then who is at risk for transmission? Well, both patients and oral health care workers. Which organisms? Well, this depends on the patient population that you care for, but you could consider respiratory viruses, bloodborne pathogens, tuberculosis, Legionella. So these are the kind of things that sort of just come to my mind when I think about IPAC and the delivery of dental care. So I'd like to share with you, I think it's 4 articles that come from the indexed literature. And they talk about infection transmission in the dental setting. Now, this first one that you see, I know it's old. It's from 1991, but it is, I really was struck by this article when I read it. It's a review article by Goodman and Solomon, and it looks at reports of IPAC lapses and outbreaks in community care settings from 1961 to 1990. And so only looking at the infections associated with dentistry, they saw in their review that most infections were related to hepatitis transmission. And that was transmission to oral healthcare providers and transmission from the oral healthcare providers to their patients. Okay, now you got to think about the time in which these papers were written. Okay, this was before we had a hepatitis B vaccine, and it was at a time when care was provided without wearing gloves. Now, look to where we are now and the number of hepatitis transmissions that we see. And what do we have? We have changes in IPAC. We have vaccine being introduced for hepatitis B in the 1980s. And then we had a change in IPAC practices in 1985 with the development of universal precautions in response to the identification of HIV. And then in 1991, we had the development, excuse me, of routine practices and additional precautions. So things have changed over time, and we've seen improvements. But what I'd like to stress is that IPAC matters here. So this is another paper. This was hepatitis B transmission associated with a portable dental clinic in West Virginia in 2009. And so this dental clinic was held in a gymnasium. It was a free clinic. And what happened was 5 cases of acute hepatitis B infection were identified. 3 were in patients and 2 were in volunteers. And when they did the investigation, the IPAC issues that were involved were chairs being too close to each other. Also, so that's design. Reprocessing of instruments. They were reprocessed, unwrapped. There was no clear division of what was clean and what were dirty instruments. They didn't use chemical indicators. They didn't it's unclear if they use biological indicators. The handpieces were not sterilized. They were only wiped off between patients. There was no air conditioning and it was really hot. So they had a really large industrial fan in the corner that was being used to cool the gymnasium. So you can imagine this very large fan blowing across the gymnasium and these aerosol generating procedures happening. There's a risk of cross-contamination. And then there was medication administration. They used local um, uh, um, anesthesia, but the patients were required to carry their stainless aspirating syringe from one care station to the next. And what those who did the investigation found was there was a lack of IPAC oversight. And now two other papers. So the first one, the outbreak of endocarditis. This was reported by Ross et al., and it was an outbreak of 15 cases of Enterococcus faecalis endocarditis associated with one dental office. Of the 15 affected patients, 12 required surgery, and one of these 12 people is reported to have died as a result of complications from their endocarditis and their surgery. The investigators found that there were lapses in practice related to administration of the intravenous sedation, including failure to perform hand hygiene, failure to maintain aseptic technique when performing procedures, how they handled the medications, because they pre-drew up the propofol and stored this medication in a locked cabinet in the bathroom, hence the Enterococcus faecalis. And again, there was no dedicated staff responsible for oversight. Then closer to home, we have this last paper by Johnson and et al. Reported on the transmission of hepatitis C in a dental office. Now, the public health unit that inspected this office went in twice. And during the first inspection, most of the issues they identified were related to reprocessing. They saw that there was a lack of separation between clean and dirty, there was overfilling of the pouches, and there was inconsistent use of quality assurance indicators to ensure that the sterilizers were functioning correctly and to direct the release of instruments. Oh, sorry. And there was release of instruments prior to completion of sterilizer cycles. But the issues related to medication administration were not assessed during visit one. So the authors decided to go in a second time and observe IPAC during delivery of care. And there they were found still that there were reprocessing issues. However, this time they also identified issues related to medication administration. Again, medications were pre-drawn. They were not labeled for specific patients. And they found improper use of potentially contaminated, unpunctured carpools taken from one contaminated instrument tray and then to another patient's tray and used for that patient. They were apparently reprocessed by wiping down with a disinfectant wipe. There was also no dedicated staff for overseeing IPAC in this organization. So there's kind of a common theme here, and that is a lack of oversight when it comes to infection prevention and control. So now bringing us closer to home and into Ontario. So this slide here shows you all of the IPAC lapses supported by Public Health Ontario between 2016 and 2026. Now, this is not all the lapses that occurred in Ontario. These are only the ones that my team at PHO supported. And so the green bars here, let me just switch to my laser. The green bars, these are the total number of lapses. So you can see we have a lot of lapses, and then we have few, and then it goes back up. So 2018 is really about around 2017, 2018, when the Ontario Public Health Standard first had public health units going in on a complaint basis to investigate regulated health professionals. Then we had the pandemic here, so we have a decrease. And then after the pandemic and things started to open up, we have the increase in lapses again. Now the blue bars, these are the dentists. And you can see that there has been a decline in dental lapses. And I think that's attributable to the good work that you did by the publication of your IPAC standard in 2018. And now we're looking at, again, lapse investigations supported by PHO 2017 to 2026. And we're looking at the reasons for the IPAC lapse. So the little short green guys, these are general IPAC practices. The blue bars, this is medication administration. And the light blue bars, these are reprocessing. So it's evident from the data that the primary practice concern is reprocessing followed by medication administration. Both practice concerns for both reprocessing and medication administration have been implicated in the transmission of pathogens. You saw that illustrated in those few articles that I presented to you. And thinking about where we are in Ontario, during this time frame, there were 61 IPAC lapses in dental settings, and all 61 investigations had reprocessing identified as a lapse, and 2 also had medication administration. So now we're going to shift gears and we're going to look at reprocessing. I think you're all probably familiar with Spalding's classification, so we'll just go through this very quickly. First, we have critical equipment, and this is defined as equipment or devices that enter sterile tissues, including the vascular system, and they are to be cleaned, followed by sterilization. Semi-critical equipment, these are ones that come in contact with non-intact skin and mucous membranes, but do not penetrate the mucous membranes, and they are to be cleaned. They can be followed by high-level disinfection as a minimum, but it's preferred that they are cleaned and then sterilized, if you will allow. And then there's non-critical equipment, which is equipment that only touches intact skin and does not touch mucous membranes, or maybe doesn't even touch the patient. And this is to be cleaned, followed by low-level disinfection. Now, this is one of my favorite slides because it shows how the reprocessing cycle, and it shows, I think, how complex it is, because many people think that reprocessing is very simple. It's just cleaning and sterilization of instruments. How hard can that be? Well, in reality, this process is very complex and becomes more so as instruments become more complex. So this slide outlines the basic steps of the reprocessing cycle. First, we have pre-cleaning. Pre-cleaning at point of use. So this is the removal of proteinaceous material so it doesn't stick to your instrumentation. And if you can't clean it right away, then it needs to be kept moist, because if the proteinaceous material sticks to your instrumentation, then it's really hard to get off. Next, we have cleaning. And cleaning in the reprocessing area can be done either manually using scrubbing and followed by the use of an ultrasonic cleaner, or you can do it in an automated way using a washer disinfector. And this is dependent upon your situation. But the important thing is instruments have to be scrupulously clean because we cannot sterilize through dirt. So after cleaning, and rinsing, because you need to make sure that you rinse off the cleaner that you used, because if you had them sitting in an ultrasonic cleaner, then you take them out, the particles that are suspended in that solution, they may stick to the instrument again. So you need to rinse that off. So you're going to rinse it and you're going to dry it with a low linting cloth before packaging. And this is really a good opportunity to inspect your equipment and to lubricate it and ensure that they have been cleaned properly and that they're still functional. Sorry, I have this lingering cough thanks to a lovely respiratory infection I had. And then you move on to packaging. And packaging will depend upon the types of instrumentation that you have and also the type of sterilizer that you have. So you want to make sure that your instruments are packaged correctly so that you can have the right flow of the steam through the package so it can touch every little nook and cranny of your instrument, and that the packages are labeled with the date, the load, the type of instrument, and which sterilizer, because if you have more than one sterilizer. And then you come to our sterilizer. In the sterilizer, you need to be looking at your physical parameters, and we'll talk about that. And you also have to be performing your maintenance on the machine to make sure it's working properly. Then we have storage. Things need to be stored clean and dry, and so that you can keep it sterile. It needs to be out of the traffic and never store anything under a sink. And then ultimately, it goes to patient use. And when you go to open your package, you need to check that the package has integrity, so it's still sterile. Look for watermarks, make sure that hasn't been compromised that way. Check the chemical indicators, both externally and internally, to make sure that this package has actually gone through the sterilizer. And all of this is underpinned by a robust quality assurance program, which starts with the education and training of staff and moves through to the use of the various indicators and reviewing your physical parameters. So it is a very complicated system, but it's very much about patient safety. So when we look at our reprocessing cycle, thinking about the Swiss cheese model, right? So each step in reprocessing serves a purpose, and we briefly touched on those purposes. Each one adds another layer of assurance. So thinking about, is the item clean enough? That's one level. Was it packaged properly to facilitate sterilization? That's another level. Was the sterilizer functional? That's another level. And then did you store your items so that they're protected? Another level. And if you have any failures in the system and those little holes all line up, then you're going to end up with an unsterile product and a risk of transmission of infection to your patient. Okay, so let's think about the cleaning process. So here we have manual versus automated. Either way is acceptable, depends on what your practice looks like. If you have a big, busy practice, you maybe want to go automated, or even if you have a small practice, you want to go automated, because this one's going to give you a more reliable, easier cleaning. But you can do it manual cleaning. If you're doing manual cleaning, you clean them manually first in the sink, under the water, and then you're going to use an ultrasonic cleaner, but you have to remove all the visible soil before placing it into the ultrasonic cleaner. You're changing the solution daily or more frequently, because if it becomes cloudy, you need to change it. And as I said, you need to rinse and dry the instruments after coming out of the ultrasonic cleaner, and you need to test the ultrasonic cleaner for its efficacy using a commercial efficacy test. Document that you did the testing, as I'm sure as you learned when you were in school, if you don't document it, you didn't do it. And the foil test is no longer acceptable for testing the efficacy of an ultrasonic cleaner. And then we move to the automated. You can use a washer cleaner or washer disinfector. But you need to refer to the manufacturer's instructions. So you need this for the installation, operation, and performance qualifications of the machine, and then for the routine testing. To make sure that the machine is working optimally, every day you need to test it with a commercially available indicator. And when it comes to the loading of the machine, you need to follow the MIFU because every machine may be slightly different. Every brand of machine may be slightly different. So the manufacturer's instructions for use are very important. You need to have them on hand, and your staff need to know where they can access them because they need to, over time, you start to think, oh yeah, I know how to do that. I know how to do that. And then your practice veers away from what it's supposed to do. Then you get that correction when you look at your MIFUs. So it's really important to make sure that you have your MIFUs on hand. And one of the trickiest pieces of equipment you have in dentistry are the hand pieces and their associated motors. And why? Because they can retract oral secretions and blood into the lumen of the handpiece, both the high and slow speed handpieces, and into the slow speed motor. And then these secretions can be expelled into the next patient. So, to stop this from happening, handpieces should be run to discharge air and water for a minimum of 20 seconds after each patient, and handpieces and their associated motors are to be sterilized in between patients. And here is also important. You need to ensure your sterilizer is capable of sterilizing items that have lumens because handpieces have lumens. And that it's capable of reaching the sterilization parameters described on the MIFUs. Is not some of the older sterilizers are not able to do this. So this is a really important aspect when it comes to the sterilization of hand pieces. Excuse me, I just need to have a little sip of water. Next, we have our water lines. And as you know, water lines are notorious for developing biofilms, and they have been associated with infections. So here I have talking about the pediatric cluster of pediatric cases of Mycobacterium abscessus. Lips aren't working. 20 children were impacted, 12 developed an osteomyelitis. So the management of your water lines is really important. Legionella pneumophilia, also a risk for your patients, but also for you as a oral healthcare worker. That's why it's important to purge your water lines at the beginning of the day for a minimum of 2 minutes, and also follow the dental unit's manufacturer's instructions. Also, do not use heaters on the water lines. The water line heaters encourage the growth of the Legionella. And then for surgical procedures, use sterile saline or sterile water as a coolant or irrigant for these procedures. So, all right, now we're going to dive even deeper into sterilizers. And I'm sure you're thinking, oh, enough already, enough of us, but it's really important to understand. Okay, first of all, there are 3 types of autoclaves. The ones that are typically used are gravity, a pre-vacuum, or a steam flush pressure pulse. Try saying that fast 3 times. It's really hard. So, as you could guess, the gravity machine, that relies on the gravity to pushes the steam in and relies on gravity to displace the air out the bottom of the autoclave. And the next 2, the pre-vacuum and the steam flush pressure pulse, are both called dynamic air removal. The pre-vacuum is the preferred type of autoclave because here the sterilizer actually pulls the air out of the chamber of the autoclave, allowing the steam to come in. But when it does that, it drops the pressure in the chamber below atmospheric pressure. And if there's a leak in the chamber, then air can re-enter the chamber. And that is not good because then this air is going to take up space that should be occupied by steam. And that's going to make it more difficult for the steam to reach all the surfaces of the items to be sterilized. So this is why you have to do a Bowie-Dick test every day to ensure that the vacuum system is adequately removing the air out of your pre-vacuum a sterilizer. And you should also be doing a weekly leak test to determine if there are any problems with the sterilizer's plumbing or seal. Okay, so and the pre-vacuum is a preferred autoclave type because it's more efficient in air removal than the gravity and is also better for lumen devices, and handpieces are lumen devices. Then we have the pressure steam. Oh my God, this one. Steam flush pressure pulse autoclave, which uses controlled pressurizations and flushes of steam. So there's no vacuum here. What it does is it pulses the steam into the chamber to push the air out. And so the chamber never drops below atmospheric pressure. Therefore, there's no need to conduct a Bowie-Dick test daily, because the chamber is always at a pressure greater than that of the ambient air. So you're not going to get a leak through your chamber. But for steam flush pressure pulse autoclaves, there is an alternate method for evaluating the efficacy of removal, and for that you should follow your manufacturer's instructions for use. And yeah, and so that's it there for the 3 different types of autoclaves. So here is your autoclave, and now we're going to talk about quality assurance, about the process challenge devices, the purpose of the Bowie-Dick, which we actually did just cover a little bit, the biological indicators, chemical indicators, and physical parameters per cycle. Excuse me. So the manufacturer's instructions for use for the specific type of biological indicator that should be used in a particular sterilizer should be followed. So there are different instructions for that. And for the purpose of the biological indicator is to assess the lethality of your sterilizer to make sure it has the ability to kill. For steam, the organism that is being used is Geobacillus stereothermophilus, and it usually comes in either strips or in vials, and you incubate these per their MIFU. So you can see that MIFUs are really important. BIs are placed inside a process challenge device, and we're going to talk about those in a couple minutes. And the BI, again, is used to test the sterilizer each day that it's used with each type of cycle that it's used. So if you run different types of cycles, then you need to run a BI on each of those cycles. Chemical indicators do not replace the need for a biological indicator because they cannot demonstrate lethality. And when you run a BI and incubate it, you also have to have a control. And this is to make sure that the BI is actually viable. So you take your BI and its control from the same lot number of BIs and you incubate them at the same time under the same conditions. So that's your biological indicator. It's really important that you run this because when we assess a lapse, we're always asking, did they do their BIs? What were the results of the BIs? It's important to know that your sterilizer has the ability to kill the organisms. So what is a process challenge device? So here's the very standard formal definition. It's an item used to provide a specific resistance to cleaning, disinfection, or sterilization process to assess the performance of that particular process. So process challenge devices are validated for the intended sterilizer. So depending on which sterilizer you have, you would use a PCD that was validated for use on that sterilizer. And you can have a biological indicator or a chemical indicator inside of the PCD or both. It depends on the situation. So for large autoclaves, commercially available PCDs, that's the norm. For tabletop autoclaves, depending on which autoclave you have, there may be a validated commercial PCD available, but you would have to check with your autoclave's manufacturer regarding that. Because of that, you can make up your own PCD, and it's really important that when you make this PCD, that it represents the largest challenge that your autoclave would meet during the course of the day. So representative of the most difficult package. So you would want to make sure that you have a lumen device in there and maybe one or two other pieces of equipment in there, depending on how you package your devices for sterilization. That needs to have the same mass, materials, lumens, and tortuous pathway. Because you want to make sure that the steam is able to find its way through the packaging to get to all the surfaces of the instruments that are inside the package. So that's the PCD. And when you're using the PCD, making your PCD, I would recommend that you make it out of old instruments that are not being used in the course of care, because you can't use your PCD as care instruments. So it would, have a set of older instruments set aside and just make that into your PCD that you run several times, that you run each day or a couple times, depending on what the cycles you're using. And then we have chemical indicators. So these can be external indicators or internal indicators. And so the external indicator is the class 1. That's this stripy one here. You see it on the outside. Sure you put it on the outside of all of your packages. And this tape just gives you a visual idea that the package has gone through a sterilization cycle at some time. And then inside, you're going to put either a class 4, 5, or 6. That's preferred that you put in a class 5 because it is better. It means it's testing against all the critical values. So you place this inside each package if it's not integrated into the package. And when you are taking the package out, if you have a pouch, you look to see either inside the package or if it's integrated, that the chemical indicator has changed to the color that it's supposed to change to. If it hasn't changed, then you have a concern and you need to figure out what went wrong with that particular cycle. Oh, I see I'm getting a funny stripe across my head. We get a lot of questions about releasing a load. So the gold standard to release your load of instrumentation is to wait for the biological indicator. And that was done inside a PCD. But if for some reason you are not able to wait, there are ways that you can do it. But the gold standard is wait for your BI. Review and verify that the physical parameters, the time, the temperature, and the pressure were correct. And this is why we really want people to have either a printout or a USB where you can have electronic record of the physical parameters. Because if you only have the little display, then you have to have somebody stand there for the course of the cycle to make sure that you're hitting the right physical parameters, and that's a lot of time. So it's better to have a printout or the USB. And then you're also going to check the external chemical indicator, did the color change? And then you're going to check the internal chemical indicator, a minimum of a 4, but better to have a 5, and did the color change? But if you're not able to wait for it, then there is a way that you could release a load. So you could run a type 5 or 6 in a PCD and then have a type 5 or 6 in every package and review and verify the physical parameters, time, temperature, and pressure, and check that your chemical indicators on your packages have passed. That's how you could release a load. If you only wanted one package out of that load and you're going to wait for the BI for the rest of them, you could have a type 5 or 6 in the package to be released. And again, review and verify all the physical parameters. And of course, check that the chemical indicators for that particular package have passed. So I know I've a lot of technical information to you. I hope that it wasn't I hope that it was presented in a way that you understand that was easily digestible. But I think that um, there's lots of great opportunities as we move forward in providing safe dental care, because that's our goal, right? We want to make sure that the care that's provided to the patients is safe. And so the opportunities that we have are education and training, which we're doing this evening, which is really awesome. Also guidance, which RCDSO has done really well. There's the standard from 2018 and the plan to update it to reflect current guidance. Also, RCDSO has checklists that are available to you.
Hello,
The other
Anne.
thing,
So sorry to interrupt. It's actually 7:48, so I was thinking that maybe we can just wrap up and have some time for panel discussion, if it's okay.
okay, all right. I'll can I just do my one last slide?
Sure, sure.
Thank you. Sorry, I knew I talked too much. So in summary, individuals receiving care expect and require safe care regardless of where it's performed. And patient care equipment and devices that are cleaned and disinfected need to be done that's appropriate to the equipment. And so thank you so much for your attention. And if you have any questions, please reach out through Communicable Disease and Control at oahpp.ca. Thank you.
Thank you. Thank you, Anne, for getting us started with this insightful presentation. And I know there is never enough time to talk about IPAC processes, so I do appreciate it. But I think it's time to move on to our panel discussion. And Anne will be joined by two panelists here, Dr. Rana Badevi, who is clinical lead quality at the RCDSO, and also Ms. Danielle Steinman, a manager with the infection prevention and control team at Toronto Public Health. And to facilitate this panel discussion, I have some pre-populated questions, which are actually based on past commonly asked queries of dentists post to the college. So that's what I'm going to ask today. So maybe I'll start with, because we have learned a lot about scientific and technical support from Public Health Ontario, we will shift our gears towards local public health units. And I will ask Danielle. I'll start with you. So, Danielle, like based on your experience of working with Toronto Public Health, what you have seen as common problems when you're inspecting after an IPAC lapse, what are the top three things you would advise dentists to prepare proactively to keep people safe?
Thank you, Sonika. That's a great question. So this is a great segue into our next session on June 24th. We're going to have a more detailed look at what to do in the event of an IPAC lapse. So thinking proactively, though, we do encourage all dental offices as well as healthcare providers to focus on a few key areas. So firstly, we recommend taking the time to review your reprocessing steps to be sure that they're consistent with the PIDAC guidance. As Anne mentioned, the best practices in IPAC are always evolving, and it's important to make a point of confirming that you are up to date. So as humans, we make mistakes. I'm the first to admit that. And even the most attentive team member can actually miss a step or complete an action out of order. We encourage teams to look proactively for where things could go wrong and consider using checklists and other quick reference tools as a way to embed best practices and the SOPs into daily routines. And something that might seem like a reasonable routine, or what we used to refer to as common sense, which I now say there is clearly no such thing as common sense, but something such as running the autoclave at night might actually present a risk, since there's no one there in the office to notice if the cycle ends prematurely, like Anne was talking about. So another area for attention in your office policies, these should cover everything from reprocessing to purchasing of equipment to coming to work when you're ill, i.e. don't come into work when you're ill. So it's important to have procedures like this in place to accompany each policy, so that all staff and everyone working or volunteering at your office or at the clinic knows how to act on that policy. So there should be a regular cycle for reviewing, updating, and actually having people sign off, be it electronically or in a binder, on the policies and procedures, and a way to ensure all staff are aware of the updates. So to talk about policy and procedures, you need a policy and procedure on staff training, and completion of training records is one area we often find incomplete or missing completely. So while we might rely on teams to guide one another for onboarding and trainer, and very often the trainer approach, it's insufficient when it comes to IPAC. There are so many details that can be missed. Something you take for granted, someone else may not. So finally, we encourage all dental offices to be sure that they have a consistent approach for stock rotation. And you may think this is a little silly, but it isn't. This avoids having to dispose of expired medications and supplies, or worse, inadvertently using something past its expiry date. And this can be anything from your local anesthetic to your alcohol hand rinse to your disinfectant. So it's very important also to label medications like local anesthetic with the date first used or a patient's name if you happen to be using multi-dose vials. Multi-dose vials are a very important topic in IPAC, and it's been for the past several years. Multi-dose vials should only be used with a new sterile syringe and sterile needle each time. These suggestions have been summarized as part of a learning and action toolkit that my understanding is RCDSO will be circulating with the certificates from this evening's session. So that's what I have to say.
No, thank you so much. And I really appreciate what you said. It looks like very simple, but then the policies and procedures, those roles and responsibility, designated roles, I think that's very important. So I appreciate that. Now I'll move on to Rana Badevi from college. So as the regulators for dentists in Ontario, one of the RCDSO standards of practice focuses on infection prevention and control in dental office. Rana, can you describe what is included in that document, the major thing, and what are the college expectations? I know it's a very loaded question, but if you can just highlight some things.
It is. Thank you so much, Sonika, for the question. So the college's standard for IPAC basically lays out the minimum expectations that every dentist must meet in order to keep their patients, their staff, and themselves safe. It brings together the key legislation, the standards, and the recommendations that are relevant to dentistry in a single document that reflects the best available evidence and also expert opinion at the time it was written. And as Dan mentioned earlier, that we are in the early stages of preparing to refresh the standard, and we expect to convene a formal working group by the end of this year. So basically, the standard walks dentists through a full cycle of IPAC in the dental office. Topics like formal risk assessment before every patient interaction, how to do consistent hand hygiene and appropriate PPE use in the office, exposure prevention and management, and of course, the most popular of them all is the proper cleaning, disinfection, and sterilization of patient care items with detailed expectations regarding monitoring sterilizers. So also the standard emphasizes that offices should have written IPAC policies and procedures, and Danielle touched upon that earlier too, that should be integrated into the office manual. But the expectation is more than just have policies on paper. Dentists are expected to implement those protocols consistently, monitor and audit them regularly, and also, most importantly, to respond to any gaps promptly and appropriately. And that's where accountability becomes really important, because IPAC, it's not something static. It's an active living program that needs to be reviewed and improved over time. In every office, the dentist is ultimately accountable for IPAC, even though IPAC is a team effort, but the standard is very clear that dentists must provide this leadership and oversight, ensure the staff are trained, and best practices are followed consistently. This also means staying up to date with emerging evidence, any changes in the guidance, and any updates to our standards. That's why we always remind and encourage dentists to check their local public health unit website for any updates, because IPAC does not stand still, and neither can we as professionals. Also, one of the important messages to dentists is about culture. Having a culture of safety where every team member in the office understands their role in preventing infection, because IPAC starts the moment the patient opens the door and enters the clinic. So also a culture where the office policies are followed, not because people believe in them, not because they are afraid of an inspection, and most importantly, where staff really feel safe to speak up if something does not look right. So in summary, really IPAC is not about it's not an add-on to dentistry. It's core to professionalism, to public trust, and to safe patient care. Thank you.
Thank you, Rana. And as it's 7:58, we just have a couple of minutes left. So I will ask to all three of you that, like, today's session was IPAC in the dental office, keeping people safe. If you could have every dentist do just one thing in their office to improve their IPAC practices, what would it be? And it's for all three of you.
I have two things, but they're tied.
Okay, sure, go ahead.
I feel like Anne will say one and all day say the other, so maybe it helps. Read your MIFUs, your manufacturer's instructions for use. And then the other thing is education is key. So education and training on all aspects within the office. I don't know, Anne?
Yeah, I also have two things. Also, I have more, but anyway, just two for tonight. Ensure that you have a designated trained IPAC person to help to provide oversight. I think that's super important. I know each dentist is accountable, but you also need to have somebody who's doing the oversight of the IPAC, and also audit your practices against either PHO or the RCDSO checklists, because that will help you figure out the gaps that Dr. Badway mentioned, and allow you to adjust as required. So I think those are the two that I would suggest. Yeah.
Rana, anything to add here?
Just one sentence. Like, I know there are many technical and scientific elements to IPAC, but I think I would say the most impactful is what dentists do every day in front of their staff matters more than anything that is written in a manual or so try to lead visibly through your own actions. Yeah, I think that's just what I have to say about this.
I totally agree. I totally
Walk the
agree.
talk.
That's the
Walk the
key.
walk.
And that concludes our panel discussion. Our conversation has reinforced key principles of IPAC today and drawn attention to the critical role of the dentist as leader in creating a culture of safety. And on that note, I will now hand it back to Dan for closing remarks.
Thank you so much, Sonika, and thank you to Anne and Danielle and Rana. This has been a really thoughtful and engaging discussion. And obviously, one of our panelists said that IPAC is not static, and these sessions are not static. There's lots of questions that have been raised over the last hour, and we will endeavor to answer as many as possible. And we also have a second session on IPAC that will be coming up in June, as I mentioned earlier. And I can't state enough some of the tips that have been provided this evening, and particularly the self-audit. I really think that the self-audit is part of the secret sauce to making sure that your entire team does a walkthrough and really looks at the resources that are available from provincial sources and from the college to check your practice and the IPAC procedures and protocols against those resource documents. So I really, truly appreciate everything that you've talked to the group about tonight, for taking the time out of your, I'm sure, very busy schedules to share your experiences, insights, and perspectives with the profession. And I want to thank everybody tonight who has joined us. And I hope that we had a good mix of dentists and individuals who are responsible for IPAC in dental clinics. For dentists, you don't need to do anything to receive your CE certificate for your Category 1 point. We will draw on the attendance records from Zoom and issue certificates by the end of next week. And as always, if you have practice-related questions following tonight's discussion, I encourage you to reach out to the college's practice advisory service, and you can also visit the college's website for additional resources. I'd also like to highlight that the college is currently consulting on a new standard of practice on managing new patient requests, and I encourage you to review the draft and share your feedback. Your input is very important in helping ensure that the standard reflects both professional expectations and the realities of practice. And finally, I'll remind you that the college maintains a YouTube playlist of all past RCDSO Connect sessions. Viewing these recordings is eligible for Category 3 CE points, and they continue to be a valuable resource for ongoing learning. I hope that you'll be able to join us for the second part of our IPAC series, which will take place on June 24th. Details will be shared by email, so please keep an eye on your inbox. Thank you again, everyone, for joining us this evening, and please enjoy the rest of your night.